Okay, I think everybody's ready. So, all right. Well, thanks so much for everybody for joining. I would like to introduce myself quickly. My name is Staci Swiderski. I am the CEO and the president of Family Source Consultants. We are a surrogacy and egg donation agency headquartered in Chicago. We have several other offices that are satellite offices, a few full-time offices around the United States. So we have Miami, Dallas, California, Washington, DC, Washington, DC, and soon to be New York. So we're in the process of that. So we're really excited about that. So basically, what we're going to discuss today really is just an overview of the surrogacy process. From the very beginning of who really needs a gestational surrogate. We're going to talk through the medical aspect. And then beyond, we have a wonderful group here of professionals and experienced people here. So I'm excited to get started. So what I'm going to do is introduce you, I think, one by one. So, and then we'll kind of go into your story a little bit, and then we'll go to the next. And then everybody feel free to jump in. And just kind of make it like a round table where, and if you feel the need to ask questions, and then I will field some of the questions that are coming in as well from the viewers. And so we'll have a pause for that as well. So let's start with Dr. Lavy from New England Fertility Institute. So if you don't mind just kind of giving a little intro, that'd be great.
Thank you. Yes, I'll keep it short.
Don't keep it short.
My name is Gad Lavy. I'm a reproductive endocrinologist, basically a fertility doctor. I have a clinic called New England Fertility that's located in Connecticut, in Stamford. I've been here for quite a few years, actually over 20 years. Initially I spent a good few years in the university at Yale, and then decided it was time to start my own. I've been here since, basically doing fertility, IVF, and in the last few years, I'd say, focusing more and more on what we call third-party reproduction, which is surrogacy and egg donation. So it's sort of a little bit of a niche. But as I'll explain later, it does have to do with the general fertility treatment, IVF, and so forth.
Thank you. Thank you. So we're going to scoot over to Katie. So Katie's been a gestational carrier or a surrogate, if you will, with our agency here at Family Source. And she recently delivered a little baby boy last month for her intended parents. So if you could just share a little bit of your story, and then we'll ask some questions, because I have a few questions right up front of my head that I know I want to ask you.
Okay, good. My name is Katie, and I am a mom of 3. I got into surrogacy sometime last year, and it was one of those things. I had mentioned it to a friend of mine that was struggling with infertility a couple of years ago, and I didn't think a thing about it after that. And it just kind of came to mind, and I was thinking, if I could do it for a friend, I could most certainly do it for anybody. All my pregnancies were easy, so I figured, hey, someone out there probably needs someone like me. So I got into it probably April last year, and filled out an application and just hoped for the best. I didn't know a lot of what went into it. I was kind of going into it blind as such, but I went with FSC just because there was a lot of good reviews, and people said that it was easy to go through the process, and it really was. It was easier than I imagined it would be. Your imagination kind of gets the best of you, but even through going through different fertility clinics and things like that, it was a breeze, really. I know a lot of people are concerned about shots and stuff like that, but even that was easy. I had my first transfer in October, and to our disappointment, it didn't take, which it happens, and you can't, as a surrogate, you can't blame yourself for that. even though you want to. It feels better to blame yourself, but you can't. And then we had our second transfer in December, and that one took very easily. And then we went into COVID season. So I mean, I'm sure it's different in previous years to be a surrogate. This year was a little challenging just with all that went on in March. You know, you make plans with your intended parents to do, you know, all sorts of things, get together, and, you know, then you have to just use a Zoom call to meet with them and talk with them and text back and forth. But the pregnancy went really textbook. And then I delivered almost 6 weeks ago. So it went perfectly. My water broke at home. Went to the hospital and had him within 5 hours. So it was super fast, and the parents came, and our hospital allowed them to come, allowed my husband to be there. So it was a blessing, even in the midst of the circumstances, to have them there and to have them to be able to see their little boy born. But the whole process, I know there's always things that will happen, or, you know, that you assume that will happen during the process. And it was really a perfect first experience for me. But anyway, that's all I can think of right now. I know you had some questions for me.
Yeah, I had a question, just basically because you and your intended parents were really in the heart of the COVID,
Yes.
and the high point of that. And I know they were pretty much local to you, not too far away, in the Midwest. And
Yep.
how did that? Because I remember obviously seeing your journey and obviously being here, and they had planned to come to some of the fertility, or I'm sorry, some of the to the appointments, and that just couldn't happen. And I remember you were a little bummed about that, and they were a little bummed about that.
Right.
But do you have any kind of, you know, just advice, because people are still going through that,
Right.
you know, with the surrogates. So how did, you know, were you able to maybe video conference them in, or just take photos, or put them on, you know, on speaker maybe at the OB appointments?
For my specific OB, they didn't allow a FaceTime. I know some are different. I've seen some of the other surrogates be able to FaceTime their intended parents during that. But of course we got the printouts of, you know, the 20-week ultrasound. They were there for my 10-week, and then COVID hit. So I had FaceTime them, I think, before that, just as a normal conversation. But as far as being in the OB and letting them view appointments, it wasn't allowed in ours, which it's understandable. You just kind of have to go with the flow, you know, in the circumstances. So
You got your and he's here. So, well, I'm glad that they were able to be there for the birth. So I
yes,
thought that
me too.
was pretty amazing. So
Yeah.
that's great. So I want to move over to Karla. Karla, so she is the executive vice president here at Family Source, and she's pretty much a pioneer in the industry. So welcome. We're happy that you're here to just offer any of your expertise. If you can just share a little bit of your background in the industry, that'd be great.
As Staci mentioned, I have been in the industry for quite some time now. I've been helping intended parents for about 11 years in October, create their family with the help of a surrogate. I have done a little bit of everything, so I'm very familiar with what goes into this process and how difficult it can be. I have my own experience with fertility struggles, and I had my 2 children via IVF. My first son took about 9 embryos to get to, so, you know, he was very much wanted, and I do understand how the intended parents feel after, you know, they've been trying for so long and before they get to us. So the idea is to provide support, to help them feel understood, to provide, to share the compassion that we have, because we have had some experience on the personal side as well. It is a complex process. It is a roller coaster of emotions, but always keeping the eye in the prize that is having a baby at the end. And we do appreciate so much the women like Katie that are willing to do this for the intended parents and sacrifice on their own to make this possible for them. You probably notice I have a little bit of an accent. I can't get rid of it.
We don't want you
from
to get rid of it.
So I'm bilingual in English and Spanish, and I also, help intended parents that speak Spanish with their journeys.
Thank you, thank you. So what I would like to do, Dr. Lavy, is move over to the medical aspect and kind of start from the get-go. So when you have intended parents or patients, if you will, that come to you, can you just share a little bit from your experience, what would make a patient need a gestational carrier? What do you see most commonly?
So as I'll explain maybe a little bit later, essentially what we are talking about from the medical side is in vitro fertilization. In vitro fertilization is a process that is about 40 years old, I'd say, at this point. And as I'm sure you can tell, I've been around for most of those 40 years. And for me, it's still, it's sort of amazing where we started and where we are today. So it's a little bit hard for someone who just comes in and basically needs to take advantage of this technology to understand, how far this has come and how much higher the success is today. And the fact is that, the basis of all of this is the fact that with IVF, for the first time, we were actually able to create embryos outside of the body. So you would take the woman's eggs, and you take the man's sperm, and you create the embryo, and you basically grow the embryos for a few days in the laboratory, and then put it back into the uterus. And that was, of course, disruptive, revolutionary, amazing. Still is, I think, still for me today, even after all these years, to actually be able to watch an embryo turn into a baby is pretty amazing. But and originally it was basically very simple. The process was developed essentially to bypass the woman's fallopian tube. So women who had blocked tube, absent tube, damaged tubes, basically could bypass the process through IVF. And then once the process became more commonplace, we started adding more indications. So for example, soon after that, well, a few years after that, we started using IVF for cases where the sperm counts for them. The sperm couldn't by itself get into the egg. So if you do it in the laboratory, you can actually help the sperm get in. And then one by one, we added more applications. And then the idea was, well, if we have an embryo, right, it doesn't necessarily have to go back to the same woman's uterus, the same woman that created the egg. And that allows us then to talk about surrogacy. We call this gestational surrogacy, as opposed to what we call traditional surrogacy, where a woman would be inseminated, a surrogate would be inseminated with the husband's sperm. So gestational surrogacy, again, came along once IVF was already well established. And then you say, okay, we have this technology, which is sort of pretty powerful. So who can benefit from it? Who are the people who are candidates? So the obvious answer is someone who doesn't have a uterus, right? They have ovaries, they have a partner with sperm, but they have no uterus and they need somebody else to carry for them. So that was pretty obvious, and that was the first cases of surrogacy were performed in this kind of a scenario. And then we started saying, well, there are other indications, right? So maybe the woman has a uterus, but there's some damage to the uterus. They've tried all different things. They've tried IVF. Everything is looking good except the uterus doesn't accept the embryo. So that's another indication. There is a uterus, but the uterus, for whatever reason, one reason or another, doesn't function properly. And then there's conditions where the woman has the uterus that's functioning, but has a medical condition that make it difficult, dangerous, or impossible for her to conceive.
How often do you see unexplained infertility? So they go through several IVF cycles and you just cannot, no rhyme or reason, and then they move on to the surrogacy process, which I think would probably be the most frustrating for for the intended mother. With the
Well,
unexplained.
you're absolutely right. That unexplained infertility is first of all, it's common. Even now with all the new technology and all the testing that we have, we come out basically with no explanation, probably about 20% of the 20% of couples trying to get pregnant. All the testing is normal. They do IVF, looks great, it doesn't work. Now, what actually again, part of the advancement in IVF is the fact that we can get a lot of information on the embryo. So we can grow them for 5 or 6 days, basically until they turn into a blastocyst. We can even do some genetic testing to tell us that the embryos are good. So if you have a genetically tested normal embryo that looks strong, and you do the embryo transfer, you put it into the uterus, and it doesn't work. Of course, it's disappointing the first time. A little bit surprising, right? Because we say, well, with the PGS embryo, you have about an 80% chance of success. So we say, well, maybe it was bad luck. If you do it again, everything looks good, it doesn't work. Then you say, well, it can't be just bad luck. Unless we're really, really unlucky, there has to be something else. And the thing is that we're still a little bit in the dark about how the uterus functions. So, the uterus, if we look at the uterus, we basically do an ultrasound, right? We check the lining, we check the thickness, we see how it develops. But we're still lacking the information about how it functions. So only recently there is some testing that become available. But as Staci said, you come up with the diagnosis with unexplained, everything looking good, it doesn't work. Then they said, okay, well, maybe you need to find a different uterus to carry. And if you've done all your testing and you have the PGS embryo, making that switch actually makes a humongous difference, because all of a sudden you're starting over. People of course come in with their baggage of failed attempts and anxiety, but you're starting over, and in those cases, the success rates are again very, very high for each time you do it.
What are you seeing for a success rate using a gestational surrogate, and then say even an egg donor, with a single embryo transfer? What are you seeing as far as a success rate?
So what we find, again, if you take a genetically tested embryo, and by the way, that embryo can come from an egg donor or not. Once it's genetically tested and normal, the success for each embryo is somewhere between 75 and 80%. That means, you put one embryo in, and that's your chance of having a baby.
That's amazing. I remember years ago when they used to do 3-day embryo transfers. That was when I first started, a long time ago.
So I can tell you, and again, it's taken a while for everyone to get their mind sort of wrapped around the idea that the success is higher. So yes, when we started, we were doing day 2 and day 3 transfers. We were transferring 2, 3, 4 embryos, just hoping that one sticks. And most of the time, none of them did, and occasionally one did, and sometimes all of them did. So what this allows us now to do, especially if you have a surrogate and you know that you have a good uterus and a good embryo, is to basically transfer one embryo and have a high chance of success. And that way you don't have to take the risk of having multiples, premature birth, and all the complications that go with that.
Perfect. And then what about, we typically see about 50% of our clients are of same sex. How often are you seeing same-sex couples come through?
About that. I'd say about half, or a little bit more than half of our clients are same-sex couples. So, I didn't talk about that when we talked about the indications, but yeah, of course, same-sex couples, this opens up an opportunity, because for them, that's really the only way for them to have children. So in addition to basically the medical reasons that we discussed, then, just to finish that list, there are the same-sex couples who, of course, need a surrogate, need a uterus. So for them, it's basically using an egg donor and a surrogate and their sperm. And then we also have cases where women, that's sort of a little bit difficult that basically have an issue with caring. they're healthy. They theoretically, they don't have any medical problems, but they have anxiety and fear about being pregnant. And actually, it even has a diagnosis. It's called tocophobia.
What is it called again?
Tocophobia. It's the fear of being pregnant.
Okay.
And I mean, that's a real thing. And I've spoken to many people like that. And sometimes they feel guilty because they say, well, maybe I don't really need to use a surrogate. But I think that's as legitimate as a reason as any to work with a surrogate.
Yeah, I'm sure too, in addition to the fear of just pregnancy itself, but then you have the labor and the delivery, the actual childbirth part of it, where that could be fair, for sure, fearful. So I have a couple of questions that popped up. I'm going to kind of get to them as they come. I think it would be that way we're not just doing all the questions at the end. And then I know, Dr. Lavy, you have a slide too. So I'll get to a couple of these questions, and then we would love to go through your slide as well. That'd be great. The question is for you, Katie. The question is, how long did you have to take the medications for, the injectable medications, and how horrible were they? Everybody's fearful of those big needles.
Yeah, questions are fair. That's fine. Gosh, I want to say it was just a couple of weeks because they will have you go through your cycle. I don't know, maybe 2 to 3 weeks. Dr. Lavy could probably confirm that. I really can't remember, but
so it wasn't that bad if you can't remember then.
in the moment, yeah, looking back, it wasn't that bad. And I took estrogen orally, and then I took progesterone through a needle, which some take it different. I mean, it just depends on the doctor, I guess, or I don't know. I don't know how all that works, but the shots really weren't that bad. I guess if you don't have a high pain tolerance, then it might be bad to you. I do typically, but really it wasn't. It's just
I think they look scarier.
They look scarier because it's a big needle, but it's not that bad.
Typically, what on average, Dr. Lavy, I would say probably progesterone for about 10 weeks or so.
Yeah, I think I stopped mine around 9 weeks. I think that's when I stopped mine. So, yeah. But the beforehand, before you have your transfer, it's really not that long. But then afterwards, I guess so.
Yeah. Is that about right, Dr. Lavy? How long do you typically keep your IVF patients on the injectable medications?
So first of all, I mean, as far as how long it takes to prepare, it takes about 3 weeks. So from the time, and usually starts with the surrogate cycle period, and then about 3 weeks later, she can have a transfer. Now, how you prepare is still a matter of great debate, right? Everyone has their own formula, their own cocktail. And so what that means is there's probably more than one way to do it. Typically, I mean, I would say the standard now is basically to use to basically create what we call an artificial cycle. It can be in the form of pills or injections for about close to 3 weeks, and wait for the uterine lining to thicken. And then when the lining reaches a certain threshold, you start taking progesterone, which basically is the final trigger to prepare the lining. And again, that can happen in a pill form and in a vaginal insert, or more commonly as an injection. And that's the standard, and it's very predictable. You start your period today, I can tell you the date of your transfer. What we've been trying is to, over time, to come up with ways that are a little bit more, I would say, user-friendly, patient-friendly. And that means trying to work more and more with the natural side. And, if you think about it, Katie is, a perfect example. You have children, you conceive naturally. So many of the surrogates are like that. They're young, healthy, they have normal cycles. They never needed any assistance to have children. So that means that they have good cycles on their own without help. So we actually more and more now and try to use a natural cycle and supplement with a little bit of hormone, which means like no injections, for example. So when I tell surrogates that, they're like their jaw drops because they come in, ready to do these big shots. And so again, that's an option, and it maybe not not appropriate for everyone, but that's certainly something you should try. And I personally have really good experience with it. In fact, the success is as good, if not better, in my experience, than doing the medicated cycle.
Oh, wow.
So the point is that there's more than one way to do it. I think a lot has to do with that individual, right? Their cycles, their hormones, and also with the doctor, their experience and what they're comfortable with.
And then I have a question here as well from Tristan. I'm not sure if that's a male or a female, doesn't say, but wanted to know how, for you, Dr. Lavy, in terms of, we went over the success rate, but also how long, this kind of goes along with the other question, but how long until the surrogate or the IVF patient is released from you to see their OB, about how many weeks post a positive beta?
So usually we watch the surrogate, we follow the surrogate till about 10 weeks, I'd say, plus minus. And actually what you're really looking for is to verify, to confirm that the pregnancy is good. Especially with the medicated cycle, we want to make sure that we can take you off the medications and everything continues to progress normally, right? Because at some point, usually happens about 7 or 8 weeks, the pregnancy itself makes enough hormones that you don't really need to supplement. So usually at that point, and you can tell that from blood work, you can stop all the supplements, whether it was a medicated cycle or a natural cycle, and then the pregnancy continues, and it's essentially as if you conceive naturally. So it varies a little bit from pregnancy to pregnancy, from woman to woman, but usually by 9-10 weeks, most pregnancies are sort of independent of what we give them, and that is a good point to transition.
Perfect. And then one more question from Noel. Let's see. Are most of the IVF cycles, the embryo transfers, frozen or fresh?
Well, that's a good question. So I would say that at the moment, almost all, I'd say just about all of the cycles are frozen cycles. This is, again, it took a while for everyone to sort of become comfortable with that. But the bottom line, I mean, the answer to why is because it works better. For many different reasons. From the fact that it allows us to do genetic testing on the embryos, the fact that it allows us to basically focus on creating the eggs and the embryos without having to worry about the uterus. So that way, when we have the embryos and they're frozen, then we can focus on the process of embryo transfer and even do it with a natural cycle. So there's many reasons for that. People worry about freezing, how that affects embryos. I can tell you that right now with the technology that we have, the newer technology, the embryos are no different whether they're fresh or frozen.
So you don't see any difference in the success rates at all between the fresh and
not at all. So in other words, the embryos, the survival is very high and the viability is unaffected by the. So the answer is that we don't really do fresh cycles. In what we call the olden days, right? In our world, the olden days could be just a few years ago. But we used to do fresh cycles, which means that in this case, the surrogate or whoever's giving the egg donor or the female partner would basically synchronize their cycle. And that way, the surrogate will be ready when the embryos are ready. And even without knowing the details, it's a little bit of a challenge to do that. And what that means from a practical perspective is that you always, almost always compromise on one end or the other. So being able to completely separate gives you more freedom and more.
Perfect. So while we're talking about the medical aspect, can you go over the steps that you had? I believe you prepared a few slides for those. That'd be great.
All right. So yeah, can you see my screen?
Yeah.
All right. So basically, just in very, very, very briefly, of course, you know, we talk about the process and what it takes, right? I mean, that's sort of stating the obvious. To have a baby, you need eggs, you need sperm, and you need a uterus. And the amazing thing nowadays that actually you can, I mean, for those people who are willing to take advantage of all that's out there, it's basically, you're just about guaranteed to have a baby. So if you use your egg, if your egg is not good, you can use an egg donor. If you're willing, same thing with sperm, and of course using a surrogate. So we make sure that we optimize all these three components, and that way we know that we have a high success. Just a few words about the IVF, you know, and again, the IVF, like I said, is almost, I'd say, almost a mature technology. All these things that I list here actually contributed to the fact that the success is much higher than it used to be. So, you know, to do IVF, you need to take drugs. So the woman needs to take medications to stimulate egg production, egg growth. Those drugs are injectable drugs, usually given for about 2 weeks. And basically over the years, the medications have become better. They're safer and more effective. So that's basically a big part of why IVF is better. Sperm injection, what we call ICSI, is where you insert one sperm into each egg. That also was a big, big step in allowing us to get fertilization to create embryos, even in cases where the sperm counts or the sperm motility is very, very low. We're able to grow the embryos longer, which allows us essentially to, as Staci said, we used to do day 3 or day 2 or day 3 transfers. Now we can grow them to day 5 or 6, which means that we have a better conditions that we can provide. And by doing that, just by doing that, you can tell which embryos are viable, because the viable embryos will continue to grow and those that are not will stop growing. And of course, the genetic testing is big because it allows you to, you see the graph here, it shows you just in general in IVF, the difference between using a genetically tested embryo versus an embryo that was not genetically tested. You almost double your chances of success with each transfer.
Do you feel the need? Would you recommend the PGS if the patients are using an egg donor as well?
Yes, I do. You know, I'm you know, again, there's many different opinions on this. I'm a big fan of PGS, and the reason I believe that, you know, if you're trying to maximize the chances of success with each transfer, with each embryo, you're definitely better off doing PGS. So, for example, if you take a 40-year-old woman, you find out that probably about 90% of her embryos are abnormal, only 10% are normal. So that's very easy to see the advantage. However, which to our big surprise, when you look at egg donors, these are young women, you know, basically very carefully screened, good hormone levels. Even there's about the 30 to 40% of their embryos that are abnormal. So it's not as significant, but still 30-40% is a pretty high number.
Absolutely. And you know, while you were talking about this, a question came through from, let's see, Elan. He had a question, let's see, as a same-sex couple. Okay, how does that affect the embryos if they have limited embryos? So basically, if they're splitting the eggs with an egg donor, does the PGS negatively affect? Like, basically, are they going to lose any of those embryos if the PGS is performed?
Well, you lose embryos because they're not good, right?
Okay.
So I think the thing about the PGS is more about knowing what you have, what you truly have. So you may have 10 blastocysts that look good, but only 6 of them are normal. So I mean that is true in general. For same-sex couple, we're usually what we do is that we divide the eggs right into 2, and we fertilize. We create embryos for each partner. Typically, for an egg donor, we get somewhere between 15 and 20 eggs from a cycle. And typically, from an egg donor, we get between 6 and 8 PGS normal embryos. And again, if you split the eggs, then each partner has usually 3 to 4 PGS normal, which is definitely enough. I mean, basically enough to have at least one child, usually more than.
Right.
So
and I'm going to kind of piggyback to that question on my
Yeah.
own. Are you, will you transfer 2 embryos if a couple really wants to transfer 2? I know there's a lot of controversy versus transferring a single embryo transfer and double. How do you feel about that?
So I'm showing this slide here. This is sort of, actually this slide tells you the entire story of this process, right? And just quickly to go through this, because we already talked about it, we do it basically in 2 parts. First part is creating the embryos. So we have the egg donor, or actually the female partner, taking the medication, harvesting the eggs, fertilizing, creating embryos, growing them for 5 or 6 days to what's called the blastocyst stage, right? That's the final stage of the development before the embryo needs to attach in the uterus to keep growing. And at this point, we freeze all the embryos, and just before we do the PGS. So soon after the embryos are frozen, a few days later, we get the report, each embryo, normal, abnormal. And by the way, you can also tell the gender, of course, if you want to. So then you know exactly what you have, and then you focus on the second part, which is the embryo transfer. In this case, the surrogate, right? So you find the surrogate, you do all the testing, make sure she's good, and you prep her with whatever protocol you use. And then you have, of course, to Staci's question, you have to make a decision, right? Do we do 1 embryo or 2 embryos? So I would say, we never do more than 2 embryos anymore. Typically, I think for most cases, I recommend we only do 1 embryo, just because of the risk of twins. And I'll touch on that in a minute. So if you look at the success from just the sex perspective, 75% with 1 embryo, over 90% with 2 embryos of having 1 or 2 children. And then out of those, 60 or 70% will be twins.
Okay.
So when I counsel couples about what to do, so first of all, you need to tell me if you really want to have twins, right? If you're going to do 2 embryos just in order to increase the odds, that's not a good choice.
Right.
Now, if you say, okay, we want to have twins, and actually many of the same-sex couples prefer to create embryos for both partners and transfer 1 from each partner. So then we have, we sort of have a discussion about that, because, the risk of twins is clearly higher than the risk of carrying a single twin. However, you have here an opportunity, the advantage, when you're using a surrogate, to actually look at this person's history. Right? So not all surrogates are candidates to carry twins. And essentially, you have to find someone who's not only able, based on her history, but also willing. So, and Staci can probably talk more to that, but of course, it's a little bit more difficult to find that person. So even if you find someone who we think can carry twins, so her risk of having early delivery is much less than someone who's never been pregnant before, but it's still higher than if she was only carrying one. So it's a tough decision, really is.
Yeah, a lot of times we'll have intended parents who start the process. They'll reach out to us and they're really adamant about transferring too. And then after about a week or two, maybe 3, they've changed their mind and they've done a little more research as well, and they prefer to transfer one. And I think, like you said, with the PGS, the overall success rates, you really want to minimize, the high risk pregnancies, because the goal is a healthy baby. Not twins that are, in the NICU or born prematurely. So, but we still have quite a few intended parents who will definitely only want to transfer to.
And we're not even talking about, what happens when you have 2 healthy kids born at the same time, right? You have to handle that. From my perspective, it's just making sure that you end up with a healthy child.
Absolutely, absolutely. Katie, what was your stance on that? When you were starting the process, you have your requirements as well that you're looking for within your intended parents. Did you have a preference, 1 or 2 embryos?
I really didn't, just because I felt like, once we had a good match, I could kind of fill out the intended parents and, kind of see what their thoughts were. But I really didn't mind carrying 2 just because I have had healthy pregnancies, but of course it was up to them of what they wanted to do. So it really didn't matter to me.
Okay. And Dr. Livy, I have a question here as well. This is actually from Carol in Connecticut. What is your experience using frozen eggs, donor eggs, versus fresh trans egg donor?
It's again one of those issues that continue to evolve. So if you asked me a year ago, I would tell you for sure that fresh eggs are better than frozen eggs. Today, I'm almost ready to say that it's the same. We've worked a lot with egg freezing. We've developed our own protocol, our own method. Just that and freezing eggs is, the egg cell is the most difficult cell to freeze in the body because it's the largest cell in the body and it has the highest water content, which makes it more susceptible to the damage from freezing. So it takes a lot more experience, a lot more expertise to be able to get basically good viability, good survival, good success. So, and the problem is that it depends on where the eggs come from, my opinion, because there's all these egg banks, and so it's a little bit difficult because there's so much out there, and there's really not a whole lot of regulation on that to know for sure that what you're getting is the same, right? Because what you want is something that's the same. So when women, for example, come in now, we have women coming in to freeze their eggs. That's again a new thing now that is possible because they fear, they're getting older. They fear that their eggs are going to run out of eggs, or the quality will deteriorate. So I used to basically tell people not to do it because I didn't think that the technology was good enough, and I think that you have this false sense of security that you have 10 eggs frozen and you can use them and have a baby whenever you're ready. Right now I'm more comfortable doing that still, with the understanding that we're still not 100% there. But anyway, make a long story short, I think we've come a long way, and I think frozen eggs are almost as good as fresh.
Yeah, we're seeing a lot more intended parents that they're concerned they have with using a fresh egg donor, basically, an excess number of embryos. So I guess that's also a way to control that, not having an astronomical amount of embryos, or even one extra embryo. Many people are a little conflicted with that. So I guess that's definitely a way to control that as well.
Yes, for sure. I mean, frozen eggs, in theory, have advantages. You can control the cost, you can control the number of eggs that you get. You know ahead of time how many eggs you're going to have, which you don't know for sure with egg donors. So, you can create egg banks for egg donors. All those things, I mean, they're definitely advantages. Just is the question of the technology. Is it there yet. And it, like I said, I think it's almost there.
Yeah, for sure, for sure. Katie, question for you, in terms of support through the process, through the journey. What type of support did you have on your own, as well as within the agency?
Well, first starting with the agency, 100% support from them. Anything I needed, they were right on top of it. Any questions I asked, I mean, quick response, here's what you do, you go here, we've got this covered, everything. So that was, I didn't have to worry about anything on that end. As far as support here at home, I had 100% support from my husband right off. He said, if anybody can do it, you can. That was his first words to me when I brought him, you know, this whole thing of, you know, wanting to get into surrogacy. I was a little leery of, you know, family having a skewed view of what surrogacy was all about. And that's, I mean, that's normal because a lot of people they haven't done research into what it is and what it's all about, which is fine. But to my amazement, I didn't have any negative feedback from any of my family, any of my friends, people that knew me, acquaintances, anything like that. If they were negative, they didn't say anything to me about it. So it was, I mean, support all around for me, which made it very easy. So
Great, great. And to chime on that, we also have a very solid support for our intended parents as well. So we have the support groups for the surrogate as well as the intended parents, and that's been amazing. You know, for many years we had it mainly for the surrogates, but then not too long ago we thought, you know, it's really time to make sure that the intended parents as well have support. So we have one-on-one support options within our agency as well as webinars, monthly webinars, and the feedback has just been amazing. So I think just all around, you know, IVF in general, but then you throw third party into it. I think that support is just so important going through the process for the surrogates and the intended parents, for sure. So that's something we definitely want to make sure that we are offering. Karla, in terms of, you have so much experience working with intended parents, and even on a case management side, what are some of the concerns that you've seen from intended parents, and especially international? And that's something I want to talk to you about, Dr. Lavy next. But Karla, in terms of international intended parents, what are some of their biggest concerns going through the process that you've seen?
All of it. You know, you have intended parents, not only international, but also domestic intended parents worried about whether the surrogate was going to take good care of herself during the process. They wanted accountability. They wanted to know if we were going to keep in touch with them, if they were going to be following medical advice, what kind of guarantees you can offer in regards to the surrogate not wanting to keep their baby. And it does take education, you know, because there's a lot of misconceptions out there. And, you know, Katie can probably share about her feelings with that. But what I hear the most often is that surrogates are concerned about the intended parents not taking their babies. So it's the other way around.
It's actually a question that was in here that you said that came through here, and it was actually for Katie, and it popped in right after I asked you, and was same thing. How did you feel once the baby was born? Did you feel an attachment? Did you want to feel like you just had a hard time passing that baby over to the intended parent?
no, not at all. I really didn't. I mean, I think it's in your mind from the beginning that you are getting an embryo transferred that is 100% someone else's DNA, you know? And so when you have this baby, it's not going to look a thing like you anyway. But no, I mean, in the hospital room having this baby, you know, mom was overjoyed and crying, and I was overjoyed to be able to essentially give this baby back to them because it was theirs from the beginning, you know? So there was no attachment. You know, I love them, but I don't want to keep them kind of deal. And I think a lot of us have that mindset too. You love them because you carried them, but you don't want to keep that baby. It's not yours.
Right. You're ready to kind of really get back to your normal,
yes,
you know, your, exactly. I guess, family unit. Yeah. But yeah, sorry, Perla, that just came through right when you said that, and I thought that was an interesting, it's an interesting question for sure.
That I got very often all this time. And now during COVID, I think the biggest concern is, are we going to have any travel restrictions? Are we going to be able to get there for the birth? And what kind of risks are we taking when it comes to the health of this baby and wanting to get back home? What I do tell intended parents is that the fertility clinics are very much open and continue to do the process. Dr. Lavy, you probably have international partnerships with other clinics so that the intended parents can maybe freeze their sperm and send it here to create their embryos. And you can tell us a little bit more about that, but before you do that, I also wanted to add that the process takes time. The creation of the embryos takes time, the matching takes time, the medical screening takes time, the contracts take time. So hopefully by the time that there is a pregnancy on the way and that the baby is going to be due, hopefully there will be no more travel restrictions and they can get safely here. But we do work very closely with attorneys that are experienced in bringing the intended parents into the United States and being able to pick up their baby.
Right, and returning home with no issues as well, hopefully as quickly as possible.
I would be interested to hear about how you're dealing with international intended parents and the creation of their embryos since they cannot get here.
Yeah, good question, Perla, because that's really been some of the international intended parents, that's really their only holdup. Even if they can travel, they're a little concerned. So on both aspects, yeah.
Oh, well, so we do work with quite a few international clients from different countries, Europe, Israel, China in the past, not in a while. So of course, for each country, there's their own challenges based on the law. Starting, for example, in China, where it's illegal to transport any kind of DNA material, sperm or egg. But for most other countries, it's actually possible to, for instance, to freeze a sperm sample and then ship it. So what we do for many of the same-sex couples, because for them, we just need their sperm. We get an egg donor here and we have a surrogate here. So basically, we send them to a clinic in their country where we have a connection with. They give a sample, they freeze the sperm, they do all the regulatory blood work, and then the sample gets frozen and shipped over.
Now, is that something that your fertility center will help arrange for them?
So we created partnerships with clinics in different countries, in the UK, and then in Spain, and we have Germany, and Italy, and Israel. And so it's basically, that becomes a very simple process. You just have to go there and give a sample, and essentially we can do everything without you, sort of thing. And we also have done this the opposite of actually creating embryos here and sending them back to be used somewhere else. That's much less. It's happening much less. But as far as getting sperm here is really it's pretty straightforward and pretty.
Yeah, technology has just been obviously super helpful. And then I know a lot of the concerns are the FDA guidelines, obviously as you're transferring into a surrogate. So obviously those fertility centers there in the other countries, you make sure that all of that is completely fine, no issues whatsoever.
Right. So the FDA, people talk about FDA as if it's a huge obstacle, but in reality, really isn't. You just have to be familiar with the regulations and follow them. So, for example, the FDA regulations concerning surrogates, they basically control the infectious disease panel that whoever's donating the sperm and whoever's giving their eggs has to go through at the time of the creation of the embryo. or at the time of freezing the sperm or freezing the egg. Unfortunately, it can only be done in an FDA lab in the US, which is a little bit of a hassle. But we get around that quite easily because for example, we have a lab in Spain, and with the doctor I know very well. So the guys go there, they give the sample. There's a kit that basically has the tubes. They draw the bloods, they ship us the frozen sperm, and they ship the tubes to the FDA lab. So we're all very well within the FDA guidelines, so we can do it without any problem.
Perfect. Perfect. And then a couple questions here, and then I know we'll get wrapping it up here soon, but it was a question actually for you, Katie, that came through from another Katie, actually. And she had asked, when you started the process, what were you looking for? What's important that you feel that surrogates should know? Basically, what criteria were you looking for within your intended parents?
Oh, with my intended parents? One thing that was important to me is that we shared the same morals. As far as, I know some are very pro-life, and that's what I am, very pro-life. I didn't want there to be any discrepancy or, changing your mind in the middle of it. I know that's, I wouldn't say that it's common, but if something goes wrong, you're stuck between a rock and a hard place. I didn't want that to be an issue. So morals, they had good family values. They looked to be that they worked hard at whatever profession that they were in. They loved their family. I just wanted a good, solid family aspect with my intended parents. And when we were matched and we talked, I wanted there to be a good connection between us. I didn't want it to be awkward at all. And it really wasn't. I felt like when we talked, we had already known each other for a long time. So that was important to me because you're going through this process with them for a good year.
In a while.
So I think having that good connection to begin with helps the process to go smoother because communication is good also. So
was it important to you as well after the birth, that you stayed in communication with your intended parents?
I had that mindset that if they didn't want to continue with communication, I would be okay with that. So I already had that in my mind, that if they wanted to cut off communication, fine. If they wanted to share pictures, fine. But I mean, for us right now, we still have good communication. If it trickles off in the future, that's fine. It's their family. We have our family. So we are two different people, two different families in two different locations. So it was, for me, it was up to them how they wanted to do communication from after the birth on. So.
Right, and it's so important during the matching process from an agency standpoint that everybody, the surrogate as well as the intended parents, their criteria really is met. So whether that's a single embryo transfer, the type of relationship,
right.
Location, whether it's a heterosexual couple or a same-sex couple, all of those important pieces of information definitely are looked upon before we even share profiles, because we wouldn't want one of those, a situation where it's like, oh my goodness, now you're pregnant and we're not agreeing on this. And so that definitely has to be agreed upon from the get-go.
Right.
One more question. I know we have to get it wrapped up soon. Dr. Lavy, it was for you actually. It's from Orion asking about HIV positive. Will you work with HIV positive couples?
Yes, the answer is yes, and I'll explain in a minute. I just wanted one thing to say to Katie, because, and just to follow up on what Perla said, that parents are nervous because it's a big deal, and they, of course, this whole process is about trust and about being comfortable, and they have all these concerns, and the surrogate, and what is she like, and should I take care of herself. And, just as an observer, I just sort of, I like to watch and, once the parents actually meet with the surrogate, it's amazing to see how much of that anxiety just sort of melts away. Because, it's not everyone can be a surrogate, not everybody wants to, not everybody qualifies. But I think it's an amazing group. And I have to say, don't blush, Katie. I think it's an amazing group of women. And I really personally believe that surrogates have sort of a guaranteed place in heaven for what they do. Because it's an amazing thing to do. Okay.
You got me teary-eyed on that one.
I want to answer Ryan. What was it, Ryan?
Yes, about the HIV positive, if you would work with couples, yeah.
So here we go. So we definitely work with HIV couple. And what we know that you can definitely have a child if you're HIV positive, and you can also work with a surrogate if you're HIV positive, because that introduces another element, right? You want to make sure that the surrogate is safe during the process. So essentially, we work with this program here. It's actually called SPAR, the Special Program for Assisted Reproduction. It's a laboratory in Massachusetts, in Bedford, Massachusetts. It's run by Dr. Kiesling, who is one of the pioneers on HIV research. And they basically, what they do, they are able to provide the assurance that the sperm doesn't carry the virus. And again, this could be another hour of a lecture, but essentially the idea is that even if you're HIV positive and you have undetectable virus, there is a chance that there is some virus in the sperm. And the only way to know is to basically do that test. It's called PCR. It's a test for the virus. And what Dr. Kiesling actually based that whole institute on is the fact that she did research and found that if you take men that are HIV positive with undetectable virus, and you do serial sperm samples, you find that every once in a while there's a positive sample. So they basically, we work with them. Before you do your IVF, you go there and you give a few samples. They check and they find the samples that are negative. And they, in a way, sort of give their stamp of approval. And that they also speak to the surrogate, they counsel the surrogate, they tell her their experience. And I think it's for everyone's peace of mind. I think for the parents, for the surrogate for sure, and myself included, is the fact that you can have that, stamp of approval. It does, of course, make the process that is already complicated, makes it a little bit more complicated, and it adds some to the cost as well. And I know that not everyone does this, but I think, in my opinion, in my experience, that's the right way to do it.
Isn't the SPAR program, isn't this realistically the only program right now in the United States for the HIV to test? Yeah.
Yes, yes, it is. It's strangely, it is the only program. Yes.
Nice.
So, but what they do is not. I mean, it's not a secret. I mean, they basically just do the PCR, the virus test on the semen and on the sperm. So they take each sample, they divide it up into three, and one third they freeze, 1/3 they check the semen, and the other they check the sperm. So they have a. I mean, it's a very, very accurate, very reliable, very dependable.
So you had mentioned right before that some fertility centers don't go this route. Is that, I didn't even think that would be a possibility, especially when utilizing a surrogate, that it would have to be mandatory.
Well, you know what, to be honest, I didn't think so either, but I've been very interested in this in the last few years, and I've been doing some research. So I know there are some clinics that basically do it, and they feel that, just by doing the sperm wash, you can lower the risk. But lower the risk is not enough, right? I mean, even if you have 1% or 2% chance to expose a surrogate to that, it's one thing if it's your partner, your wife,
Sure.
but it's another thing if it's a surrogate. So
Yeah.
I think you need to be, to me, 110% sure that the sperm is clear, and there is a way to do it, and it works beautifully.
Perfect. Yeah, definitely. I would definitely make it a requirement here at the agency anyways, with any of our surrogates going through the program, that was done, for sure. So I know it's been a little over an hour, so thank you everybody for your time. I did want to mention before we end our webinar, just, really the importance of the fertility center and the agency, the relationship, the partnership. And I think that's just something to really, be really valued. So we certainly appreciate it, Dr. Lavy, for sure.
Same here. I did have a slide. I didn't share it, but
We have time. We can share it. I just didn't want to take up your time. I didn't know.
Oh, it's fine. But listen, the bottom line is this is a team effort. So you have a team on both sides of clinicians, support, psychologists, and they all basically work together. And when I first present these to clients, I always worry a little bit that it's a little overwhelming, right? Because you see, there's so many different things that have to happen. There's so many moving parts, and everything has to happen just right. But the idea is of actually partnering with an agency, and working closely with the agencies, essentially being more or less behind the scenes, because a lot of the things that happen don't really require the clients, don't require your involvement. So that way, instead of being like all stress, it's mostly fun, right? It's mostly fun, a little bit of stress, but allows you then to focus on what's important, right? You have to
Absolutely.
you need an egg donor, it's a huge decision. You have to find the right surrogate that's a good fit for you, a good match. You have to be comfortable with that. So obviously decide if you're going to do 1 embryo, 2 embryo. That's also a decision. But that's it. That's it. Everything else, is going to be basically done for you, and you just have to trust. Like I said before, you have to trust, of course, the surrogate, but you have to trust everybody else that they're basically doing, the best they can.
Right. It's definitely, for the patients, the intended parents, for them, it's so overwhelming in itself, right? But as professionals working inside the industry, we know how regulated the process really is, so as long as, you're working with an experienced fertility center, agency, the attorney, the escrow, all that is so important. So definitely there are a lot of pieces to the puzzle, but that's why we're here. So yeah, definitely just the partnership that we have with your team as well. It's just that's what we're here for, is to make the process that more enjoyable for the intended parents, so they can really concentrate on what's really important, and that's the relationship.
Right, and just to follow up on that, and I know Staci feels the same way. We call it a journey, because that's.
I think I said that 20 times a day.
That's what it is.
It's a journey.
And the thing about this, it's a very, very individual decision that you make, and of course, people come from different places. Every it doesn't really matter whether you're single or heterosexual or gay. Everyone comes from a different place, and everybody has a different idea of how this should be. And there is no right way to do it, right? So, our job is essentially to try and figure out who you are, what you want, and come up with a solution for your problem. And so it really is, like I said before, there's not just one way to do it. You have to just find the right way for you.
Right, absolutely. And really treating everybody as an individual, each person is an individual, what's important to them. I think, and so many different perspectives, you know, even as an agency and as a fertility center, really looking at what's important to them. For sure. So thank you so much, everybody. I thought this was amazing. Of course, you know, Dr. Lavy, your medical outlook is always, I could listen to you talk all day long. I wish we had all day. And thank you so much, Katie, for your input. There's a bunch of questions here that we could put on our website too that were really surrogacy geared. So we'll do that as well. Thank you, Karla, of course. But yeah, this was fun.
It was fun. Thank you very much for having me, and good luck to everyone. You know, it's a little strange. I still find it strange to do these Zoom meetings, right? Especially that you don't really know who's on the other end. And anyway, I hope it was instructive and helpful.
Oh, it was amazing. I can't wait to do them again in person.
Soon.
That was a little more fun. So, all right, everybody, have a great rest of the day and week, and we'll talk to you soon.
All
Thank
right.
you.
Bye-bye.
Bye-bye.